Welcome to this explainer. All right, let's just get right into it. The word asbestos, just hearing it is usually enough to trigger a massive wave of anxiety, and, for good reason, given its history. But when a chest x-ray comes back showing something called pleural plaques, that initial fear almost always outpaces the actual medical reality. So today, we are going to completely demystify pleural plaques. We're going to break down exactly what they are, what they actually mean for a patient's health, and how clinicians manage them, using the most direct, evidence-based source material available.
Here's our quick roadmap for today. First, the asbestos fingerprint. Then, the BCN rule. Third, clinical management in action. And finally, a rapid-fire knowledge check. Okay, Section 1, the asbestos fingerprint. Anatomical markers. When a physician looks at a chest x-ray and spots these, what exactly is happening anatomically? Well, what's really interesting here is how precisely we can define this condition. Pleural plaques are basically just localized areas of fibrous tissue. Over time, they frequently become calcified, which is exactly why they light up so clearly on an x-ray. Anatomically speaking, they develop specifically on the parietal pleura, mostly right along the lower chest wall and the domes of the diaphragm. They're essentially little thickened, chalky patches on the outer lining of the lung space. And here is the absolute key takeaway. These plaques are the single most common manifestation of past asbestos exposure. They are literally a definitive fingerprint left behind by that hazardous dust. But here is the wild part. That exposure, it didn't happen yesterday. This 20 to 30-year gap represents the latency period. These plaques are a super reliable radiological marker of asbestos contact that typically occurred 2 to 3 decades ago. Just imagine that. A patient breathes in asbestos fibers in their 20s or 30s, and the plaques don't even show up on a routine scan until they hit their 50s or 60s. It is literally a ghost from the past showing up on today's imaging. Now, understanding that decades-long latency can obviously cause a lot of panic for a patient.
Which brings us to Section 2, the BCN rule. Clinical reassurance.
The BCN mnemonic is your golden rule for reassurance here. Seriously, if you remember nothing else from this explainer, remember this. B stands for benign. So the absolute most crucial point is that pleural plaques have zero malignant potential. They do not turn into mesothelioma. They are 100% benign. C stands for calcified parietal or diaphragmatic distribution. This just reminds us of their classic symmetrical appearance on imaging, telling us, hey, these are standard plaques and not something more sinister. And N stands for no restriction. Uncomplicated pleural plaques do not impair lung volumes. They don't cause restrictive parenchymal lung disease on their own. They literally just sit there, quietly documenting history. And this brilliantly illustrates the anatomical divide between the safe stuff and the dangerous asbestos-related diseases. Look at how the source material splits this up. On one side, you've got the parietal pleura, that outer layer. This is where our benign plaques live. It's the safe zone, just a simple marker of exposure. On the flip side, you have the visceral pleura and the interstitial lung tissue itself. Now that is the dangerous territory. That's where you find asbestosis, which causes severe fibrosis and, of course, malignant mesothelioma. Visually anchoring this distinction in your mind helps clarify exactly why plaques, isolated to that outer parietal layer, are safe.
So, if they're safe and completely benign, what do doctors actually do about them? Let's move to Section 3, Clinical Management and Action, Action Pathways.
This 4-step action pathway comes directly from clinical protocols. Step 1, clinical history. The doctor has to document a detailed occupational and environmental exposure history to really establish a timeline. Step 2, radiological review. They need to confirm that classic bilateral calcified appearance to make sure these are benign plaques and not something dangerous like diffuse pleural thickening. Step 3, reassurance versus imaging. This is a total fork in the road. If the patient is completely asymptomatic, the standard management is simply reassurance and documentation. No routine repeat imaging is necessary at all. Step 4, specialist referral. But what if things aren't routine? You only refer to a respiratory specialist if the patient is symptomatic or if the imaging is atypical.
Which brings us to the detective work. While the plaques themselves are benign, patients with a history of asbestos exposure are obviously still at risk for other diseases. So clinicians must actively monitor for specific red flag symptoms. If a patient with plaques suddenly develops progressive shortness of breath, unexplained chest wall pain, a persistent dry cough, or constitutional B symptoms, like unexplained weight loss, night sweats, or profound fatigue, actually, scratch that reassurance because that changes everything. These red flags tell the doctor it's time to worry about coexisting pathology, like mesothelioma or lung cancer, and they need to escalate the investigation immediately. And when those red flags do appear, or if a standard X-ray looks a bit atypical with new pleural thickening, this is the exact tool they reach for. The investigation of choice is a contrast-enhanced CT of the thorax. This isn't just your basic X-ray. It's an advanced, highly detailed scan that perfectly maps out the pleura. It allows the clinician to evaluate the chest for hidden nodularity, suspicious soft tissue masses, or expanding effusions that would tip them off that a malignant transformation is happening right alongside those benign plaques. All right, we've covered the anatomy, we nailed the BCN rule, and we went through the clinical action plan. Section 4, Rapid Fire Knowledge Check. Top exam questions. Get ready to answer these in your head before I reveal the truth. Question 1. Let's test your recall on the most anxiety-inducing part of this whole topic. Do incidental calcified pleural plaques discovered on a routine chest X-ray carry a risk of transforming into malignant mesothelioma? Think back to our mnemonic. And the answer is a resounding no. Remember the B in the BCN rule? They are benign markers of past exposure with absolutely zero malignant potential on their own. Okay, question 2. This is an anatomical one. On which specific layer of the pleura do characteristic asbestos-induced pleural plaques form? Remember that side-by-side comparison we did of the safe zone versus the danger zone? The answer is the parietal pleura, usually most commonly involving the diaphragm and the lower chest wall. This outer layer location is a totally defining characteristic of their classic benign appearance. Moving right along to question 3, focusing on clinical management. For a patient who is completely asymptomatic but has incidental plaques found on an X-ray, what is the standard management when it comes to routine follow-up imaging? No routine repeat imaging is required at all. As long as the patient remains entirely without symptoms, documenting the occupational history and giving him solid reassurance is all that's needed. We definitely don't just scan for the sake of scanning. Okay, final question. Let's make it an advanced diagnostic one. We know we reassure asymptomatic patients, right? But under what specific circumstances is a more invasive procedure, like a pleural aspiration or a surgical biopsy, actually indicated for a patient who has pleural plaques? The answer is only if there is an associated pleural effusion, meaning fluid is actively building up in the lung space, or if that contrast-enhanced CT scan reveals a suspicious soft tissue mass or nodularity. That is exactly when you suspect something way beyond a benign plaque, and you absolutely must refer to a specialist for a biopsy. And that brings us to the end of our structured breakdown. By understanding the BCN rule, the distinct anatomy of the parietal pleura, and those specific red flags to watch out for, we've basically replaced panic with protocol. So I want to leave you with this final provocative thought to consider. If a patient has a 30-year-old asbestos exposure, are we treating the fear of the past or the specific medical reality of today's X-ray? Armed with the facts from this explainer, you now know for sure it's purely the latter. Thanks so much for joining me. Keep learning, and I'll catch you in the next explainer.